Sanjay and I are great colleagues back in Yorkshire. We're part of the Yorkshire Humber Network, and Sanjay is the chair at the Yorkshire Humber Network currently. But he's been pushing us very hard, and in fact, Jenny and Emma, who are also here from northeastern Yorkshire, pushing very, very hard on our addressing poverty-proofing education around that, and making us more aware of the situation in which our families live. So all about that, Sanjay, we're going to hear about what you've been up to.
Yes.
Thank you very much.
Oh, thank you, Fiona, and thanks to the NPDA team for sending out this invite. So what I'm going to do is share a journey, a quality improvement journey, which our team sort of embarked on late in 2022, relating to addressing some of the inequalities in view of the deprivation in our region. So this work was done in collaboration with this charity called Children Northeast, that's based in Newcastle. And I'll be using a terminology called poverty proofing, but the team at Children Northeast has got the copyright over that. So if you look at the national statistics, 1 child out of 4 children in UK is living in poverty. So if in a clinic we see 12 families or 12 children, then 3 out of those will be from poorer backgrounds. And why it's important is that, like disability, poverty is not always visible. So if we don't sort of understand, that some of these families are actually in dire poverty, our approach during consultation may be quite different. So I'll be just sharing some of the experiences we have had. Now, this slide, I think, is well known to us. This is the Core 20+5 approach proposed by the NHS England way back in 2021 for the adult population. And then that was extended to pediatrics to change the key clinical areas relating to discrepancies in the outcomes relating to asthma, diabetes, epilepsy, oral health, and mental health. The Core 20 and the plus element remain the same for adults. So, of course, the Core 20 is the most deprived 20% of the national population based on index of multiple deprivation. And the plus element is left open to the ICBs. So that could be inequalities relating to, say, coastal communities, traveling communities, and the likes. So, of course, Justin has gone through this, and I'm just repeating it. So the blue bar is our unit, and this is the percentage of children using insulin pump by demographics. So in our region, the blue bar, the least deprived or the most affluent population, about 50% of them are using pumps, and the most deprived, only 15%. So that discrepancy seems to be much higher in our unit compared to the regional and national statistics. And the similar discrepancies there for the CGM use. So almost 70% of our most affluent population is using CGM compared to about 40% from the most deprived. And I think Justin has covered this in the morning. So the outcomes in terms of median HbA1c. So for the MDI users, for our unit, it was 68.3 millimoles per mole. And for the pump and closed loop systems, it's between 53, 56. And that's the 2021-22 data. So obviously, if we are not offering technology to children from the poorer backgrounds, the outcomes in terms of HbA1cs is bound to be poor. So when we talk about equality and equity, equality is like giving same resources to everyone irrespective of their background. And I don't think we are even doing that. So I don't think we have reached even the equality stage. And what we should be aiming for is the equity, at least. And of course, it's not to say that the MDT is not putting in efforts for these children from the deprived backgrounds, but because they've got so much of social, psychological factors as well. So most of the time from the nurses probably is taken up by addressing those issues, and the technology somehow is left behind. So the aim of this poverty proofing project was to identify barriers to engagement for families affected by poverty, to understand the consequences of poverty on individuals and the families, and basically focusing on interventions, taking into account the feedback, direct feedback from those who have this lived-in experience of poverty. And the underpinning principle of this work is this. So no activity or planned activity should or will identify, exclude, treat differently, or make assumptions about those who have less financial resources. And this statement is important because if you remove the last bit of it, who have less financial resources, you can change it to any of those with some protected characteristics. So that could be disability, those from ethnic minorities, and things. So I think it's quite a powerful principle. So this slide I showed, and I think what we should ultimately be aiming for is the third slide, where you are actually trying to remove all the barriers so that nobody is identifiable based on any protected characteristics. So this was the intervention. So we had discussion with the ICB and within the network. Emma has been a part of that from the start. So we had an agreement with the Children Northeast team in September. And the stage one was in November 22. So this was a training for all the team members, including the admin staff, of 3 hours relating to consequences, implications of poverty. That highlighted lots of subconscious biases, prejudices, presumptions of the team members about poverty and deprivation. And then they had a consultation with the staff, about 30 to 45-minute interviews about trying to understand, are there any provisions to address the needs of children coming from poor background? And our business manager was also interviewed on that one. And then they did a scoping exercise. So they shadowed the staff to understand the service for 5 days. In December 22, there was the team again visited, talking directly to the families, children, and young people, one-to-one discussions, focus groups, and online questionnaires. February 23, they came up with a very comprehensive, detailed report, which was like about 42 pages long, identifying key areas where the service could focus on. So they identified lots of good practices, direct comments from the users, and then some recommendations. And they're going to visit again next month to see has anything changed and what has the service done in order to address the need of this population. So there were 8 proposed themes, actually, and where the interventions could be put in place. And I'll be focusing on just the 3 to give you a flavor of what this work involved. So what I'll be doing is just some couple of comments from the service users and some interventions which we have put in place or trying to put in place. So relating to transport, some of the comments were most people out in the periphery have to get 2 buses if they don't drive. If the families are working, people just assume you can get time off. So many families were on a 0-hour contract. So, if they come to the appointment, then they're losing a day's pay. And then they have to bring the children along. And there was a comment to say that it is a pride thing. So if families are struggling with finances, they will not always be open about it. So they may not attend the appointment, but say that, sorry, they didn't receive the letter, or they had something else which came up. So then I think we looked at, are there any things in place which people can use? So there's each trust apparently has the hospital travel cost scheme. We were not aware of it. Our business manager wasn't, and our admin staff wasn't. So this, we have made it more visible now in the clinics so that families can tap onto that and use. On our hospital website, there's this bit about regular outpatient attenders. They are entitled for free parking. And again, it says to contact the reception staff. And when we asked them, they had no clue about, how they should be able to support these families. So we have put that bit in place, and then we identified the 2 postcodes where there was the most frequent DNAs from, and we're trying to set up outreach clinics on those locations to see if the uptake will be better. With technology, I think, there's the team from Luton is talking about, and I think Gateshead team has done a big work on this. So this comments were like, I feel it's the kids from not so disadvantaged background that get the technology. So that is like, the lived in experience. And the phone, of course, that's an extra bill. Then you have to add on the cost of computer and things. So parents have given their phone to the kids. So now we've changed our, so at diagnosis, the technology is discussed universally with all the newly diagnosed patients. And at the first clinic appointment, the clinic sheet includes the question about technology access, and we are revisiting that on our annual review sheet. I think, again, Jenny and the team in Northeast have done quite a lot of work on refurbishing, using the refurbished equipments, and we are struggling with that a bit. We have had discussion with our IT team, but our ICB manager, Katie, is looking at it at a regional level. And then there was about food, so waiting for review. So this is about the clinic efficiency. So if a child has got an appointment at, say, 12, 11 o'clock, and we are running an hour late, if they're entitled for a free school meal and that takes over their lunchtime at school, they miss out on that. And there were families and comments to say that some children will go without food after breakfast and they haven't eaten in the afternoon till the tea time because they've missed that. And then, of course, the snacks. So the hospital canteen, the cost of the snacks is higher compared to the local shops. Plus, then some families had this preconception that only certain snacks should be used, which were branded and things, and they were spending quite a lot of money on that. So these two interventions have been put in place. So our dietitians are holding regular sessions about eating on a budget with diabetes. And now we have got coupons for the families. So if they're waiting around lunchtime, so they have got coupons so they can get a free meal from the hospital canteen. So, of course, when we started working on this, it seemed like, it's a big, big, ambitious task to address. We have just tried to address a tiny bit of it, relating to poverty, deprivation in diabetes. So it's a huge mammoth task. And as Justin was saying about the PDSA cycle, we are just about completing our first cycle. And then we'll be reviewing the data when the team visits in February and then see what other interventions we'll have to put in place. Now, this work started, so the teams participated from Northeast, North Cumbria, and then the Yorkshire and Humber, so Gateshead, Hull, and Grimsby. And we found it so useful, so our managers were able to put out the training, the 3-hour training throughout these regions. So about 210 professionals have been trained on the poverty proofing work. So, of course, it was a big consorted collaborative work. So Karen McNillis was the program manager for the ICB. Now Katie has taken over. Emma has been crucial from the start. And then my colleagues, Varghese, Kavitha, Sarah, Nikki, and Jill are participating in it and trying to drive through some of the actions. And Teresa has been a big support as well. So I feel that, and the children and young people, parents, because without their input, I don't think we would have known, what are the gaps in the service. So I think once we have put the action plan in place, we are hoping that in 2 years' time, we'll try to revisit this. And the biggest improvement would be if we see the NPDA data improving in terms of technology uptake for the most deprived population. So that was it from me, really. I'm happy to take any questions.
So fantastic work, and I have to say I have been practicing as a consultant for many years, practicing medicine for over 40 years, and the 3 hours that I spent with the team on poverty proofing were the most insightful that I had done probably ever in my training. And I have to say that now the team, our team back in Leeds, because we were all there, it was almost mandatory training for the team, have quite a different approach to families that we've been discussing. And as a national movement, Sanjay, I know what you have done with the 5 different stages is quite onerous. And That's just exactly, you're saying, oh, it's quite a lot of work, isn't it? And I said, well, yes, but I don't think we all need to do what Sanjay has done, but what we all have to do is lessons learned. Because for the work that you've done, you could make recommendation to every single centre in the country, because none of us will be that different. And I think from a national network perspective, we had a conversation with the leads for the national network regional areas to say that actually for the coming year, this is work that we all must address. And the network managers that are all over there are in the process of engaging the team, isn't that right? Yeah. And making a march on this actually right across the country. So just a little bit from me, but brilliant, and I cannot recommend it enough for your clinical practice. Any questions? I'm not going to do too much because I'm handing over to Holly for the table, but any questions at all that you would like to ask Sanjay before we move on to Holly's tabletop exercises? Oh, sounds a bit sort of... No questions, Sanjay? Does everybody think they feel their team could benefit from these insights? Do you think it's a good thing for us to do en masse based on your learning?
Yeah, I absolutely recommend that.
Yeah. Disability allowance for using for phones, etc.
So, of course, like, they do get the disability living allowance, but I think, and they do use it, but sometimes they are in such dire poverty that that is not enough for them, to be honest, so that has come through. And in fact, because as a part of the well-being questionnaire, which we do at the end of the year, annual review, so we've added one question relating to finance as well on that. And you'll be surprised how many families are actually ticking, because when we introduced that, the team's concern was, what do we do when they say, yes, they are struggling? But I said, let's get the data first and then see. So, yeah.
There's always something we can do, isn't there?
Yeah.
Something. That's great. Thank you so much, Sanjay. It's a great start.